I think this is a sufficiently important issue, and there's sufficient interest on the committee, Senator Cassidy, Senator Whitehouse, and others, that we ought to focus, Senator Whitehouse, I wonder if you agree, we ought to focus some extra time on this and maybe organize a way to see how we can help get a result.
I think we should. It might even be helpful to have a group of us kind of meet on a regular basis offline and try to put something together for the committee to consider. This is a bipartisan issue. It's about doing it right versus doing it wrong, doing it stupid versus doing it smart, and we ought to be able to work together on it.
I agree with that. So we will do that. This has been a helpful hearing. It's been 5 years since we've really had the Senate's really taking a look at this. We're moving into an era of after providing a lot of money, $30 billion for incentives, we're now going to start collecting penalties. My own view is that, well, before I ask that, let me ask Mr. Duvall, just so I'm sure, do you charge an hourly labor fee for upgrades?
If the customer needs assistance in the upgrade, which often they do not, yes, we do.
But often they do?
I'm sorry, let me take that back. Not for upgrades. So that's part of the maintenance cost that's built into the licensing fee. I misunderstood your question.
You do not charge an hourly labor fee for upgrades?
That's right. For creating those new connections, we do. That's what I thought you were asking about.
Yeah. Let me ask a question in this way. Assuming we on the committee wanted to spend the next several months trying to fix the problem here, my own sense of it, and this shows a bias about government, is that the federal government does a much better job when it is an enabler or encourager rather than a mandator, and that there are also some things the federal government just doesn't do as well as the private sector. And also that is just an inevitable law, whether it's Republicans or Democrats, that regulations just pile up over time. So let me ask each of you now, if you'd reflect on this, and then maybe you could think about it after the hearing and either provide in writing or in the subsequent activities that we have your thoughts. If you were in our shoes and you looked at the $30 billion that had been spent, and you looked at the promise of the idea, and if you looked at the fact that about half the doctors who are a part of Medicare reimbursement would rather take a penalty this year than be involved with electronic health care records, what are the first 2 or 3 things that you would do if you were in our shoes to try to realize the potential of expanding the use of healthcare records through more physicians and more doctors to the advantage of patients? And let's start with you, Dr. Adler-Milstein.
Sure. So I think in the category of enabler, I would begin with focusing on transparency. And this is really about transparency in terms of how the frontline physicians experience both the usefulness and usability of the system, the connectivity of the system, and the cost associated with these. Part of the challenge has been it's been very hard to get information on this, and therefore we have uninformed consumers.
Information from whom?
From the frontline physicians. So it would be great to be able to say, you know, we have a consumer report style set of information so that really compares the system, compares the cost, compares the value. We don't have that basic information, and we therefore can't have a robust market around these tools.
Dr. Wergen?
Well, a couple of suggestions I'd make is interacting and having electronic health records that work with the workflow of my day-to-day operation of what I do, particularly in family medicine. We as an organization started a task force that included an efficiency engineer we hired from outside at the American Academy of Family Physicians to look at just that instead of just complaining, how can we do it? If there were standards that said that. Regarding interoperability, I do want to say that it shouldn't just be a data dump. I mentioned that patient I had that I had to call and get a fax copy of the record. It was 18 pages long, and I wasn't sure why she was seen in the ER. My own small system that I operated in a 20-bed critical access hospital has a different EHR than mine. I have to log out of mine, go to theirs in my own system to find out if one of my partners.
But where do we start to change that?
I would say if there's some certification standard, we're working on making specific suggestions on how that interaction can take and workflow. From my standpoint, and that's what this is all about, is patient outcomes. The electronic health record's a tool. It's not delivering care. It's helping me deliver the proper care. So having meaningful data that I can get from my partner to me, or me to my other partner, and set standards and move away from bullets on billing is what we have now.
Mr. Duvall.
Thank you. The first few things that come to mind are to be descriptive rather than prescriptive. The meaningful use programs they were meant to be an adoption and an interoperability program, as I understand it, largely successful on the adoption front, but rather than focusing on interoperability and describing the kinds of outcomes that people wanted, it ended up becoming an EHR design session by committee. So I would much rather see an incentive to have the kinds of outcomes we all want to have, and then there will be incredible innovation both at the clinician level and at the vendor level to make that happen in a variety of ways. And I agree with Dr. Wergen here that we don't need just data dumps. So that was also something that was very prescriptive, that this is the data that needs to be shared no matter what the use case was. And there were also very artificial incentives to do that sharing. So you mentioned the fact that you had to get a patient to send you a message about nothing so that you could qualify, or send all of the information that you have on a patient because you're transitioning their care, and for an electronic transition of care, you have to send everything. So getting rid of artificial incentives by incentivizing the kinds of outcomes that we want to see, and refocusing MU on interoperability.
Dr. Kennedy.
I agree with the previous comments. I do have one comment, though, and I think that, the road to interoperability is long, and it's a journey that we have to, it's critical that we continue on. At some point, while I understand the business of business is business, we have to stop leveraging profits at the expense of the care that's given to the patient. In my daughter's case, I created the record that is carried across state lines to the provider. Both providers, or all of the providers, did have electronic health records, yet none of them could share the data. It was shared via fax, or it was copied and given to me. We have to make sure that we can exchange data in a way that providers receive the information that they need to care for the patient. In my daughter's case, 2 faxes went to organizations that were not healthcare organizations before it ever arrived in my hands. Had I not been diligent to copy and carry the records, I don't think that they could have diagnosed or been able to take my daughter off of some of the medications that she had received for 9 years. In looking at this from the consumer's perspective, it is important. And while not every consumer is going to go in and demand a copy of their information, certainly they do own the data and they are entitled to it, because that data, wherever it is created, is going to lead to better continuity of care that's provided to me, you, everyone in this room. It's critically important that we can continue to work toward interoperability and remove the barriers, whether they're on the side of the developer, the provider, even maybe with the consumer. I don't think that it should be prescriptive in terms of what interoperability looks like. I think that that is going to present with another barrier to innovation, and we want companies to continue to be innovative. The current portal that my daughter uses is a widely used electronic health record system. The information that is in that portal is not adequate to support care across the line. So if we were to go in as a family and pull that information from that portal, it is not every piece of information that we need to continue her care when we cross the state line 6 hours away and she needs something. So I still continue, even with electronic records, to copy and carry records with us wherever we go. So much work needs to be done in this area. I don't disagree with any of the comments. However, I don't think we're moving fast enough on the issue.
Thank you. I see Senator Franken. Dr. Franken. And we'll let him take 5 minutes of questions, and then we'll wind up the hearing. But and I'll wind it up after Senator Franken has a chance to comment.